If you've ever woken up and felt like the ceiling was just spinning completely out of control, well, you know exactly how terrifying that can be. Today, we're taking the vague and often super frustrating symptom of dizziness, and we're going to transform it into a totally solvable clinical puzzle. In this explainer, we're building a highly structured diagnostic funnel. We'll decode the inner ear using two really simple but incredibly powerful variables: time and triggers. So here is our roadmap for decoding dizziness today. 1. Approach to the dizzy patient. 2. BPPV, focusing on seconds and position. 3. Neuritis and labyrinthitis. 4. Meniere's disease and episodic vertigo. 5. Peripheral versus central red flags. And finally, 6. Management and vestibular compensation. Okay, let's dive right into Section 1, Approach to the dizzy patient. The absolute golden rule you have to remember here is that not every dizzy patient should be treated the same. To really build a mental map of the vestibular system, we use a specific diagnostic formula to separate the benign stuff from the truly dangerous. And the very first step, it is always sorting symptoms by duration into 3 distinct buckets: seconds, minutes to hours, and days. Once you have that time frame, then you start filtering by triggers, hearing symptoms, any neurologic signs, nystagmus patterns, and physical exams like the audiogram. Moving on to Section 2, BPV, which is all about seconds and position. I want you to think of the inner ear as this microscopic, highly sensitive mechanical machine. Now, in BPPV, what we basically have is a mechanical failure. Microscopic calcium crystals, which are literally just tiny ear rocks called otoconia, break loose. They detach and float right into a semicircular canal, usually the posterior one. So what happens? When you move your head, those heavy little rocks physically shift and they hit the ampulla, which is the canal's delicate motion sensor. That direct hit triggers a brief, really intense burst of vertigo, along with repetitive eye twitching that we call nystagmus. So how do we actually prove this is happening? We use the Dix-Hallpike diagnostic maneuver. By briskly taking the patient from a seated position right down to a head-hanging position, we are purposefully tipping those rogue crystals. And then we just watch their eyes closely. If it's BPPV, after a brief delay of a few seconds, you're going to see a classic torsional upbeating nystagmus. The eyes repetitively twitch, and then, eventually, the response tires out or fatigues. Now, BPV recurrence is incredibly common, but the beauty here is that the fix is just pure physics. Particle repositioning maneuvers, like the Epley maneuver you do in the office, or the half somersault maneuver a patient can do at home, they work by physically rolling that debris right out of the affected canal. You're literally tipping the crystals back into the main chamber where they belong, and you can repeat these maneuvers as needed. All right, Section 3, Neuritis and labyrinthitis. Now we're jumping down the funnel from seconds to days of vertigo. We're looking at acute vestibular loss, which is often triggered by a recent viral illness. And the rule of contrast is absolutely vital here. Vestibular neuritis hits you with days of prolonged severe vertigo that peaks pretty quickly, but crucially, there is no major hearing loss. The central nervous system just needs time, days to weeks, to compensate. But if unilateral hearing loss or tinnitus accompanies those exact same acute vestibular symptoms, well, that changes the diagnosis entirely to labyrinthitis. That means cochlear function is involved too. It raises the stakes significantly, making us look for causes like otitis media, viral infections, or even meningitis. And that is exactly why getting an audiogram is a mandatory part of evaluating these patients. Now, what's really fascinating is how we confirm this peripheral injury at the bedside using the head impulse test. If a patient has a damaged nerve from, say, neuritis, when you do a quick head turn toward that injured side, their eyes will actually lag. They will literally slip off your nose, off the target, and right after that, you'll see these corrective catch-up saccades where the eyes rapidly jump back to center. It's a real-time physical sign of the vestibular system failing to keep up. Section 4, Meniere's disease, focusing on episodic vertigo. Next up, we hit our minutes to hours bucket with Meniere's disease. A strict diagnosis here actually requires a very specific clinical pattern, or triad. You need more than one episode of definite vertigo lasting at least 20 minutes, plus documented hearing loss and a feeling of oral fullness or tinnitus. Conceptually, we blame this on endolymphatic hydrops. Basically, think of it as a fluid pressure buildup that's swelling the compartments of the inner ear. And a really critical takeaway to remember: while surgery is an option after medical failure for severe disabling vertigo, absolutely no surgical procedure is going to bring back a Meniere patient's lost hearing. Section 5, Peripheral versus central red flags.
Okay, we need to completely shift our mindset here because the rules are changing. If a dizzy patient comes in displaying central danger signs, we're talking a severe new headache, diplopia or double vision, dysarthria, facial weakness or numbness, vertical or direction-changing nystagmus, or maybe severe ataxia where they literally cannot even walk or have an abnormal cerebellar exam, this is not your routine peripheral ear problem. These red flags completely override standard ENT management. They scream central nervous system pathology and demand an urgent neurologic evaluation and an MRI.
Finally, Section 6, Management and Vestibular Compensation.
Understanding the why behind our management logic is so important. Vestibular suppressants, things like meclizine, diazepam, or promethazine, they are amazing for controlling acute vomiting, but they have a major catch. They must be stopped quickly. Why? Because they actively interfere with the brain's natural ability to compensate and heal after a peripheral vestibular loss. So we stop those meds early, and instead we push vestibular physical rehabilitation, which actually helps that compensation process. Remember, the vast majority of vertigo is non-surgical. Surgery is the absolute last resort, reserved only for disabling one-sided peripheral disease when we are absolutely certain of which side is affected and we've totally excluded any central brain dysfunction.
Let's burn this high-yield summary right into your memory. BPPV is seconds with position and epilepsy. Vestibular neuritis is days without hearing loss and an abnormal head impulse. Labyrinthitis adds hearing loss. Meniere is recurrent 20-minute-plus vertigo with hearing loss, tinnitus, or fullness. And central red flags always override routine ENT management. You now have the exact framework to decode the diagnostic funnel of dizziness. So the next time the room starts to spin, will you know exactly where to look?